in our public safety, mental health, and substances, breaking down the walls. This session is based around culture and policy development. Just a little bit of housekeeping. If you can try to mute your phone or computer, that would be appreciated, although people are welcome to jump in at any time if they have questions for Jeffrey. We're going to try something a little new this time because we noticed that it seemed people were a little more comfortable talking when the recording was off. So the Q&A session at the end will not be recorded. We'll shut the recording off at that time. And I also just want to mention, if anybody's more comfortable, little dots up the corner of your screen, you can change your name. You don't have to have your video on. Anything that makes people more comfortable sharing their thoughts is fine. And then my email is on here. If you have any additional questions, I think you all have that by now. So just a little bit about my program, which you probably mostly heard, but we'll go through it again. Our mission statement is that we aim to ensure comprehensive, coordinated, and easily accessible prevention, treatment, and recovery services for those impacted by opioid use disorders in the Central New Hampshire region. And our vision is that we'll build a community to prevent, treat, and promote recovery from opioid use disorders. The program will create a local system that is free of barriers, easily accessible, and fully integrated at every point of contact to reduce opioid misuse and promote healthy lifestyles and promising futures. And our presenter, who's been with us for our first two sessions as well, is Jeffrey Stewart. He is the founder and owner of Dragon Shield Consulting, interim president of the board of directors for the Capital Area Recovery Community Organization. He is the chief of Brookline Ambulance Service. Excuse me. He is an accomplished healthcare executive with over 30 years of experience in all facets of hospital operations and emergency medical services. From practitioner to educator to leader, Jeffrey's proven record of operational success, team development, and problem solving is driven by his empathetic passion to assist and care for others, including patients, clients, colleagues, and community. And I will pass it over to Jeffrey in just 1 minute here. The recordings of the sessions will be available on our YouTube channel. And I can send this out to the links afterwards, along with Jeffrey's slides. If you have any questions going forward, please feel free to email me. And without further ado, I'll stop sharing, and you should be all set to share.
Excellent. Well, thank you all very much. And again, thank you to the Central New Hampshire Community Opioid Response Program for having us come. Just give me 1 second while I share my screen. There, and if I put that in slide mode, it's in slide mode now, correct? Excellent. All right, so again, thank you all very much for coming. As Tara alluded, especially last session, it became very apparent as soon as we turned that recording off, there was some good conversation, good questions, and good interaction. So I really would like to have that tonight or today as we wrap up. This is our last session. We've done 3. So I just kind of like to move right through. For those that might be joining for the first time, this is a lunch and learn. I have about 20, 25 minutes, maybe 30 minutes of material, and then we do a Q&A or open discussion and back and forth. So that's really what we're after. And again, this isn't to credential anyone as peer support or credential anyone as an interventionist. It's just to really lay down some foundational components so that hopefully you can develop your own peer support program and or be more open and aware of some of the issues surrounding public safety, mental health, substance use disorder, et cetera. So I had opened the session. There's our objectives. I don't need to read them, but this is our focus for today, and we're going to go through it. Keep in mind, I'm sharing my screen, so I'm going to rely on Tara and Emily if people raise their hand or make some kind of gesture on their video screen, because I can't always see it. And please don't hesitate to speak right up. I do like questions and would look forward to your interactions. This is really a program for you, the attendees. So let's jump into it. I'd like to review a little bit of the 2 previous sessions because there was a fair amount of information. Today we'll get into some policy and procedure stuff and some cultural awareness and a little bit of the how-tos or where to go and some union versus non-union discussions. But what we covered in the past, I really wanted to kind of start off with who we are when we talk about public safety, and those are our corrections folks, our emergency dispatch, EMS, fire, and law enforcement. And I think a lot of times people forget that emergency dispatch is really part of this group of individuals. We talked about a lot actually on the first session about the rescue personality and really getting down to the core fundamentals of who we are as individuals and how that impacts how we handle some of these stressful situations. We are the ones that run towards the screams, towards the bullets, and towards the burning buildings because that's who we are. And that poses some unique challenges when it gets into this type of topic and subject matter as it relates to us being the ones that are suffering from it. Stigma, of course, the obvious is easy, the negative comments, things like that. But then we also discussed a little bit about some of the inconspicuous things. It could be in the way a memo or a policy or a poster or an information bulletin is posted in and around the station and around your safety complex or your duty bases. So things to be aware of. We talked about stigma. We talked about barriers. Why is there such an issue for us as public safety individuals to seek assistance and to seek care when we need it? Well, a lot of that has to do with the rescue personality, and we'll reiterate a little bit of that today. But it boils down to a lack of knowledge and fear. And really, there's a lot of fear, and the fear sometimes is inconspicuous, and sometimes it's blatantly obvious. They're fearful for losing their job, not being promoted, being passed over for promotions, blackballed, weak, et cetera, et cetera. We talked a lot about that. So, and a lot of that is really knowledge and how we were brought up in the profession from early to where many of us are today in our career. We talked about treatment options and things like that in WMD, not WMD, sorry, wrong class. WDM, that's a trick for my dyslexia. And that's really about withdrawal management. So if somebody was or having significant issues with alcohol, for example, or other substances, there might be a withdrawal management level of care. IP referred to inpatient. We talked about PHP, which was partial hospitalization, IOP, which is intensive outpatient. OP is your standard outpatient process. We talked a little bit about EAP and peer support as it relates to levels of care and or levels of potential treatment, intervention, and that type of stuff. We also talked about measuring, and this is really important for management and leadership. Do you have a handle on your staff? And I don't mean from a, I put out a directive and they follow the directive. They know their policies and procedures. They know their job. They're competent. I'm not talking about it from that perspective. I'm talking about, do you have a handle on where your overall department is with their level of stress, their quality of work versus their quality of life? And we talked about measuring that within a department, and that can be very advantageous for leadership and just middle management for that matter, in terms of ultimately impacting morale, but also where is your risk. And then we talked about actual intervention strategies, and really this was more of an awareness of terminology and an awareness of programs that are available. My disclaimer, because my attorney would be very mad if I didn't throw in my disclaimer. My disclaimer is I'm not training you to be interventionists. I'm not training you to be peer support individuals in this topic. I'm putting it out there so that you're familiar with some of the terms, some of the credentials, or some of the issues you might come across if you start to look at this within your own department or multiple agencies or your town for that matter. So questions on any of that thus far, just kind of reviewing what we did in the first 2 sessions. Hearing none, seeing none, moving on. So today's focus is not only what is peer support and a peer support model, but also some of the policies and ways we could implement it. And then ultimately, and this is where I'll get the chief's attention, funding. We'll talk a little bit about funding and some opportunities for that. So a lot of times when we talk about peer support, this is that image that pops up into people's heads. And there's a group of people sitting around in a circle and chatting. And it's a little, I'll say it because I am, you know, fair disclosure, I've been in this profession for over 35 years. It's a little kumbaya-ish. And it looks a little too soft and warm and fuzzy, and that may not be reality. This is the image in people's head, and it goes back to that stigma and misinformation. So I just throw that graphic out there just because that's kind of in our heads. It's not always like that. Sometimes it is really over a cup of coffee or a, you know, a lunch or something, or just 15 minutes in the parking lot before you end or go on shift. We'll talk a little bit about that in a second. But here's our official definition. It's a group of people with shared experiences who come together to help each other address stressors, challenges, solutions, etc. of that common experience. And that's a very broad, general definition. But for us in public safety, it's really, it could be one-on-one. We'll talk about that in a second, but it could also be a group like you see the picture here on the screen. The commonality is the profession, is the public safety model, is the fire service, the EMS service, the emergency dispatch, law enforcement, corrections. That's the common experience. And the stressors that come with that have built up in not necessarily a positive format or a positive fashion. So there is a ton of commonality between the different specialties. And I'm going to continue to really focus on public safety as a whole, as opposed to an individual law enforcement peer support or an individual fire service peer support. I'm going to talk about public safety peer support, but that's our official definition. It is confidential in nature. Now, there's an exception to that, and we'll talk about that when we get to the policies component, but a core fundamental component of peer support is confidentiality. And that becomes incredibly important when we start to deal with public safety people. We are hypersensitive. We are, and I don't mean hypersensitive in a bad way, but we are very, very cognizant of misperception, of public leakage, and loss of what I would call public trust and public capital. And when I say capital, I don't necessarily mean dollars and cents, but that validity that our organization or the individual brings because of what they do and who they are, that has value. And we run the risk sometimes of that negative publicity that takes away that value. And that impacts us when we're trying to budget justification, trying to expand a department, trying to deal with a tough issue, public credibility, public trust. It's all about public capital. And it is a tangible thing, difficult to measure, but it is tangible. So confidentiality becomes key in that. And then if you go back to some of those barriers that we were talking about, you know, and stigma, without the confidentiality, that perpetuates the stigma and perpetuates or reinforces those barriers. Peer support is evidence-based. We've been doing peer support in different avenues for years and years and years and years. So my public safety people that are on this Zoom conference today, or you have staff within your department that are pursuing, you know, advanced degrees or like to do the research or are a little, you know, tech savvy, there is tons of research out there showing the benefits of peer support programs. It is truly evidence-based. It's not a whim. It's not a fad. It's not a trend. It's been around forever. Not forever, but it's been around for 30, 40, 50, 60, 70 years. Not always in public safety. That might be a little newer. However, peer support as a thing, as an entity as it in and of itself is evidence-based. And there are various types of models. And I mentioned a little bit the group model that you see the picture of here. There's also that one-on-one model and formats thereof. So there's a various types. And if you can pick a topic, there tends to be a support group for it. Everything from Overeaters Anonymous to cancer survivors to widows. And then as you kind of look deeper into that, it really starts to be, well, it's peer support, the common experience, that commonality that ties them in. And in our case, it's public safety. Numerous models out there. Fire has a version, law enforcement has a version, corrections I know does a subset off the law enforcement. And of course, there's substance use disorder peer support. There's all kinds of various programs out there. They all have various acronyms, they all have various titles, but they are based in some key fundamentals: evidence-based, methodology, and confidential. I do highly recommend, and the evidence supports, there has to be training, not only for the facilitators, if you're going to do a group fashion like you see in the picture above, or if you're going to create a one-on-one peer potential, you've got to train the individuals. Not only the individuals who are actually doing the peer-to-peer support, but the individuals who may step up and run or facilitate a group. And there's an educational criteria for the administration that is supporting and agreeing upon and ultimately funding a peer support type model. So lots of education and lots of training. I do run a public safety support group. It's called PSEO, which is Public Safety Supporting Each Other, PSEO. And so I've got experience doing this, but more importantly, when you're sitting there in a group model and you're going to talk about a heavy subject like suicidal ideation, that facilitator needs to be trained so that we can have an open conversation about the thoughts and stresses surrounding suicide and be able to differentiate between somebody who is actually suicidal versus somebody who's just talking about suicidal ideations and dealing with those types of stresses in the life. And of course I jump right to the big elephant in the room, and suicide is obviously a hot topic, but there's training there that needs to occur. Now let's also be very specific with public safety. Everyone's armed. So if your facilitator is working in a group and they're working closely with somebody to get them to have a little breakthrough moment, that facilitator needs to be very cognizant and well aware that there is a 90% chance, if not higher, that that individual and several individuals within that group are armed, and usually with more than one armament. And I say that because this is things that people have to keep in mind. So if you're looking to develop a peer support group, if you're looking to develop or educate facilitators or again, peer supports, keep in mind when we're dealing with public safety, we're all armed. And it doesn't matter if you're in law enforcement or corrections or fire or EMS or emergency dispatch, we tend to be armed in some way. And of course, we're also trained. So that just changes the environment and changes the kind of the atmosphere surrounding the peer support. Now, amongst the individuals, it's norm for us. But if that facilitator and or that person who's actually working the peer support themselves, they have to keep that in the forefront of their mind, because it becomes a safety issue for them, but also for everybody in that room. And if you're going to open up a wound and you're going to discuss a tough subject matter, you're going to push a few buttons, you need to be very cognizant about what's coming down the road or what potentially could be coming down the road 45 minutes after that meeting, an hour after that meeting, or at 3 a.m. when the individual is at home by themselves thinking about the meeting they just had and we've opened up some wounds. We got to really keep that on top of our head. So again, I can't stress enough, training for the facilitators, training for the peer supports. It's a safety issue for everybody involved. The silo effect. I've alluded to it, and this is why I intentionally talk about peer support in a public safety model, because there is programs out there that are strictly quote unquote fire-based or law enforcement based or healthcare based or corrections based. And I am not a fan of that. That's why when we went back to our very first session, I spent some time talking about the rescue personality. That's what we're dealing with. And here in New Hampshire, the silo effect, not only, well, the silo effect in general practice, I'm not a fan of. I think there's way too much commonality between all of us that we can do much better work with each other and supporting each other by taking away some of that silo effect. But also in the bigger picture, in terms of administratively, there's more funding operations or funding options if we stay out of the silo effect. And we'll talk a little bit more about that in a second. You got to have management buy-in. If you don't have management buy-in, this isn't going to work. So this is not only a management buy-in, but it's also a union buy-in. This is where the management and union really have an opportunity for collaboration. We'll talk a little bit more about that in a second, but you got to have that buy-in. If you don't have the buy-in, it's not going to work. And I do want to emphasize here, peer support is not therapy. It's not therapy, it's not therapy, it's not therapy. I'll tell you it one more time, if not 100 more times, it's not therapy. It can be comforting, supporting, and therapeutic in nature, but it is not therapy. So I do want to differentiate that. That also becomes very, very important when we're trying to battle with some of the stigma and some of the barriers. Peer support is not therapy. Just want to get that out there. So challenges, I think, you know, I know I looked briefly or I've had conversations with Tara on some of the audience and some of the attendees. So I know that we have some administrators and some chiefs and some sergeants in the audience. So challenges, let's talk about those. We're the rescuers, not the rescued. That was stuff we talked about in session 1 and 2. We talked about stigma, we talked about fear. It boils down to a lack of knowledge. NIMBY, for those that aren't familiar with that term, is not in my backyard. For us in public safety, not my house, right? It doesn't happen in my house. My morale is fantastic. The guys love the job. We handle our issues internally and everyone's fine. Well, that in and of itself could be a barrier if that's the attitude and position of the administration. So NIMBY is a barrier or a challenge and needs to be worked with. Lowry list, I'll go ahead and put it out there. My law enforcement and corrections officers, you know what that is. That is a valid concern, not only from the administrative side, but certainly from the union side, the individuals, and it can be addressed. So I just want to put it out there. If you're thinking about doing this in your department, put it right out on the table and have that conversation, because this is something that's one of those inconspicuous little things in the back of a lot of people's mind, is they don't want to end up on the Lowry list or Lowry list, depending on how you pronounce it. Funding, yes, funding can be a challenge, but we have some opportunities here. ARPA, which is the American Rescue Plan Act, has a lot of money hitting towns. There may be some opportunity there. SAMHSA, which a lot of public safety, unless you've got a healthcare background, you may not think about SAMHSA, but it's the Substance Abuse Mental Health Services Administration. They do a lot of grant funding, tons of grant funding, and again, all surrounding mental health and substance abuse issues. Well, we're no different, and we're looking for funding. Here's two key components. They like rural, which all of the state of New Hampshire falls into except Nashua and Manchester. So take Nashua and Manchester out, but all the remaining part of the state falls under the federal rural definition. So keep that in mind for funding. And SAMHSA likes regional. So how do we do that from a public safety perspective? We get rid of our silos. So if I'm looking at developing a peer support in X town, I'm going to talk about or work with the public safety agencies within that town, but I might also tie in the 2 or 3 other small towns around me. And now we've got a regional approach, And when it comes to federal funding, they really like the regional approach perspective. So again, that goes back to what I was saying earlier about let's try to diminish silos as best as we can. I certainly respect there's a difference, a little tweak difference between a firefighter and a law enforcement officer, a corrections officer and a paramedic. Sure. But go back to peer support and go back to that rescue personality. We are a lot more alike than people give us credit for. And when we're talking about these types of subject matters where you'd be doing a peer support model, it is very, very similar. Very incredibly similar, scary similar. So I would really encourage you to decrease silos and look at a regional approach, and that might facilitate some of your funding. All parties need to buy in. So that includes our unions as well as our administration. Again, I can't emphasize it enough. It is a joint adventure, not only from the administration and the union, but also the town. Because again, if we're talking public safety, unless we're a private agency that's contracted by the town, in which case it's a little different. But if we're talking about a municipality agency, then we do ultimately need either our aldermen or our selectmen, whatever, or your town council, whatever your town governance is. They need to have buy-in, and that's an educational opportunity. But it's a much stronger buy-in when both the administration and the union are presenting jointly to the select board. So that's my 2 cents on that. Part of our job as the administrators or as the people trying to develop, we want to measure, educate, and partner. So we want to measure what is where are we at from a ProQL or a life stressors indicator component within our department. And you can issue those out. I gave you those tools last week. You can certainly do them from a blind perspective or an anonymous perspective, and then get a heartbeat on your department. You all know I'm in healthcare, so I'm going to use healthcare references, but you can get a heartbeat on it. Then you have the opportunity for education, both internal and external. And I say internal, it's within the department, all legs, unions and administrators. But then the external component is really to the selectmen or whatever your town council or your town governance body is. And then the partnering component, that's when I said, if you're going after some funding, there's funding available, and the federal funding really, really likes regional components. So there's an opportunity to partner. The other thing too is when we're talking about some of our more rural areas, we're small towns, small departments, just 3 people, 4 people, 5 people might be the entire department. So get in together with 2 other departments. Well, now I've got 20, and now we've got some impact. The goal, the ultimate goal, is to save lives. They're our lives, they're our peers' lives, to save careers, because, well, to save careers and to save money. And Jeff, we're talking peer support. How do you save money? Because you just talked about funding a peer support. Said, well, if I've got members in my department that are dealing with these stressors, they're not performing their job to the utmost of their capabilities, or if they're just covering it up and they're getting by, that's costing me money. It's also a risk injury issue because they could get hurt on the job or get somebody else hurt. That's going to cost us a ton of money. And then God forbid they end up doing something dramatic that either results in a serious injury or career-ending injury and or a life-ending injury. That is going to cost us a copious amount of money. And because I know we have administrators, it costs a lot of money to train up an officer. It costs a lot of money to train a corrections officer, a firefighter, or a paramedic, EMT, a dispatcher. There's money spent. And the longer they've been on the department, then there's more value to that individual, and you're going to take that away from the department. You're going to lose that. That ultimately will cost you money. So there is both a saving lives, saving careers, which is the right thing to do, but there's also a save money component. And you know, I'm not afraid to put it out there. It's not an unreasonable consideration. 1022.51, if I just have to remind you, remember suicide is the 10th leading cause of death in the United States. It happens to be number 8 in New Hampshire specifically. There are 22 veterans per day. There are 5 first responders. You know the definition of first responders: corrections, law enforcement, EMS, emergency dispatch, and fire service. And there's 1 active duty personnel, active duty member that are killing themselves. That's per day. And people, you know, they challenge me, Jeff, where are you getting these statistics? Well, these statistics are coming from the CDC, Public Health, DOD, and the VA. That's where I pull all those statistics, 1022.51. So that's the type of stuff we want to impact. And developing peer support and having a good, solid peer support program significantly reduces that potential. So let's move on. I'm trying to watch our time here. Let's move on to policies. Drug-Free Workplace Act that's 1988. It says 98, but that was actually 1988. So there's an error on the slide. I will fix that before I send it out. 1988, Drug-Free Workplace Act. Folks are familiar, just give me a yay or a nay or a thumbs up or something. Keep in mind, I can't see everybody. If anyone's not familiar with it, this was an act specifically coming out in the 80s. So the whole war on drugs timeframe, Reagan, Bush, actually it was under Bush when it was signed in, Bush 1. Reagan had completed his 8 years. But this was designed from a workplace perspective where drugs, and it was initially geared at drugs, and not having drugs in the workplace. That's what it was geared at. It's evolved a little bit in that it includes a couple other things that we'll talk about. But people always say, well, you know, we're a municipality. It doesn't impact us. We're not contractors, because anyone who's got a federal contract of $100,000 or more must comply with this Drug-Free Workplace Act from 1988. But it also impacts any and all grant recipients, no matter how much money you get in grants. If you get $50, you've got to have a drug-free workplace policy in play. So those of us that are in public safety, we get grants all the time, and they're for a fair amount of coin. So something to keep in mind. It includes not only keeping alcohol and illicit substances out of the workplace, which is the obvious. It talks a little bit about medication use. And this is something that we in public safety, it's going to flip into something in a second here, but we need to be cognizant of, because if somebody is struggling and they're on some medications that may impact their judgment and or their fine motor skills, that can be a problem. So there should be a policy in place to deal with medication use. And I'm not talking about necessarily urinalysis, mandatory drug testing and that kind of stuff. This can all be part of it, but just the simple stuff of, oh, I hurt my back last weekend shoveling snow and the doc gave me a muscle relaxant, Flexeril, for example. Well, you probably shouldn't be taking that for a few hours before you go on shift, because that can have some impact. So things like that we need to think about. And I think administratively we forget sometimes about those types of things. And of course, I can't mention medication use without mentioning the New Hampshire medical marijuana, which, as we all know, came out in 2013. Whether you support it or not, fair disclosure, the first time it came around, I wrote some letters not supporting it through the New Hampshire Police Chiefs Association. And the first time it came around, we were successful, but we weren't successful in 2013, so that we do have medical marijuana here in New Hampshire. That's New Hampshire. Right now, we have about 12,000 patients who are, quote, qualified to be receiving it in New Hampshire as of May 2021. There's 1,250 certifying providers, and there's about 580 caregivers. Why do I put these numbers out, and how does this impact the public safety peer support? Well, PTSD and insomnia are covered conditions under the Medical Marijuana Act. Something to keep in mind. So again, it might be clear and not an issue in law enforcement, but I can guarantee you there's some departments here in New Hampshire, because I've consulted with them on the fire service and the EMS side of things, that this has become a challenge. And some of their staff want to go ahead and utilize medical marijuana because they're having difficulty sleeping, or they're having some acute stress reactions, et cetera. And it is allowed in New Hampshire since 2013. However, let me go back to this for right now. Like it or not, agree with it or not, marijuana in the United States is still a Schedule 1. It's still on the DEA list as a Schedule 1, and it's still a prohibited substance at the federal level. I'm not arguing with the state. I'm just saying at the federal level. That goes back to the Workplace, Drug-Free Workplace Act, which impacts our grant dollars. So if your department allows for medical marijuana, you have a potential of losing your grant money because you are not in compliance with the Drug-Free Workplace Act of 1988. And as of today, still, marijuana is listed as a Schedule 1. I put it out there because this just needs to be on our radar when we start to have conversations with unions, or we start to talk about, drugs and medications in the workplace. This will come up. I have consulted with various departments within the state of New Hampshire and New England, including a couple of school districts, because this comes back into the school district as well, because again, a lot of the school districts are getting grant money. So just keep in mind, I understand what the state of New Hampshire did. Whether I agree with it or don't, doesn't matter. It's there. But we as public safety folks have to be really careful, because a lot of our budgets are grant funded, and grant funding is coming from the federal level. And there's always a line in the grant funding where you have to be compliant with federal regulations. Drug-Free Workplace Act from 1988 is one of those things. And that's an opportunity where we could lose funding. So I just want to put it out there. I'm not taking a position one way or the other on it. I just want us as public safety administrators to be cognizant of that. EAP policies, again, opportunities for you to develop one. And when you're developing the EAP policy, we have to talk about who can access it and how do they access it, and then how is their referral made. So not only is it easily available to access within the department, the numbers are posted. Bathrooms are great places to post those types of numbers. But how does a supervisor refer a subordinate? That too should be in that policy. And that's what I mean when I say referral. So how does somebody get referred to an EAP? And that could be an early opportunity. If you have Primex offers EAP through our Primex. At least that's how we get it in Brookline, is through our Primex contract. Do you have a peer support program? And again, if you're going to have a program, you're going to have a policy. If you're going to have a policy on it, you want to how do we access it? Who's on it? How do they do a referral? And then confidentiality. And it's not when I say, doing a referral, it's what if happens and when do I notify, but everything's confidential until it's not. And what I mean is, it's confidential that we're talking about the stressors and we're talking about our significant other relationships, husbands, wives, et cetera. It's also, and that's confidential for sure, but it may become not confidential if that person turns from actual suicidal ideations or homicidal ideations, or threats are made. Now, law enforcement, they get that, and they're usually really good on that fine differentiation. But when we're talking with other public safety agencies, sometimes it's a little more difficult. But the peer support group and the peer support model is confidential, yes. The time the confidential breaks is when a person is actively threatening to kill themselves, actively threatening to kill somebody else, or there is a disclosure of a minor assault and battery. In law enforcement, you know what that means. But for us, if a minor is physically or sexually assaulted, that breaks that confidentiality requirement and needs to be reported. So when you're developing these peer support programs, education surrounding that, open conversation surrounding that, and then actual policy of how does that get referred up the chain and how does that get addressed needs to be part of that policy development. Okay, I'm going to take a breath and a drink of water, and I'm going to open it up for y'all. If you have questions, please, please, please unmute and fire away. I can't see you all, so.